Good evening, everybody. Let's start this session. Today we have Dr. Abhijit Chatterjee. He is a cardiologist based at Calcutta. He is working as a clinical, invasive and non-invasive cardiologist at Rabindranath Tagore Institute of Cardiac Sciences at Kolkata. Very knowledgeable person, and he has put in a lot of efforts in echocardiography, both for teaching as far as for his practice. With this few words, I'll hand over a mic to Dr. Abhijit Chatterjee for his presentations. And once we have his presentation, we'll have a question answer session. This is up to you, Abhijit. You can start your presentation.
Thank you, sir. Can you hear me?
Everybody can hear you easily.
Okay, sir.
Go ahead. I'm listening to your talk in between.
Okay. Good evening, friends. The topic on which we are going to discuss this evening is cardiomyopathy. The question arises, what is cardiomyopathy? At one time, cardiomyopathy used to be defined as diseases of unknown etiology. The definition has changed, and nowadays we say that these are diseases of cardiac muscle, not necessarily idiopathic. They are a combination of one or more of the following: inappropriate ventricular hypertrophy and or dilatation, systolic and diastolic dysfunction, and arrhythmias. Tell me one cardiomyopathy which does not have any of these features. You can't. Cardiomyopathies are broadly classified into primary and secondary. Primary cardiomyopathies are those which are of unknown etiology. Secondary cardiomyopathies may be infiltrated storage disorders, toxic, endocrine, autoimmune, chemotherapy induced, and so on. Friends, even then, try to understand that the definition is fast changing, because as we will discuss, even for the primary types of cardiomyopathy, various genetic and other etiologies have been discovered. So first, let us start with dilated cardiomyopathy. There are two pictures on your screen. The picture on the left is a post-mortem specimen of a normal heart. The picture on your right is that of dilated cardiomyopathy. You see that the apex to base dimensions have not changed. They are virtually unchanged. But all the dilatation takes place in the transverse direction. See, it has dilated in the transverse direction. So to sum up, there is four-chamber enlargement, left ventricular hypertrophy may or may not be present, valves are normal, and the annuli are dilated. What happens when the annuli are dilated? There is poor coaptation of the valve leaflets, leading to functional regurgitation of the mitral and tricuspid valves. We will see that as the discussion progresses. Histopathology, look at the picture on the left. This is a picture of a normal heart muscle. These are the myocytes, and this is from dilated cardiomyopathy. You see in between the muscle cells, there are strands of fibrous tissue. Fibrous tissue cannot contract, and so the contractility of hearts with dilated cardiomyopathy is depressed. To put in a nutshell, these are the 2D characteristics: normal wall thickness, four-chamber dilatation. The LV is spherical in shape instead of being elliptical, and there is poor systolic function, leading to global hypokinesia and decreased ejection fraction and fractional shortening. This is a patient of dilated cardiomyopathy. Look at the left ventricle. The ejection fraction is very poor, maybe 20 or 25%. and all the segments of the left ventricle are contracting poorly. Same patient, parasternal long axis, and see that the contractility of the septum and posterior wall are depressed. An M-mode picture. Look at the contraction. See, these are the diastolic dimensions, and this is the systolic dimension. There is hardly any difference between diastole and systole. See the posterior wall, they are also same. Friends, this is a question which I frequently ask you. What do you mean by kinesis? If you look up the dictionary, kinesis means movement, but in echocardiography, kinesia means something different. It is systolic thickening. Normokinesis is about 1.4 times the diastolic thickness. Hypokinesis 1.1 to 1.3. Akinesis less than that. This is the E-point septal separation. Normal less than 7 millimeters. Here it is increased. There is reduced aortic dance. This is aortic dance, the up and down movement of the aorta, aortic wall. And there is gradual closure of the aortic valve leaflets. See, normally it should be like a parallelogram, but here it is tapering to a close, means that in the later part of the systole, the outflow decreases, and that causes gradual closure of the aortic valve leaflets. What are the Doppler findings? Increased E by A ratio, decreased IVRT and deceleration time. There is functional mitral and tricuspid regurgitation because of annular dilatation. The pulmonary venous diastolic wave is much greater than the systolic wave, and tissue Doppler shows all the waves are decreased. Look at the color Doppler findings. See, here is an eccentric jet of mitral regurgitation, and you can see the jet hitting the wall of the left atrium and coming back as a red jet. Actually, they are one and the same jet. This indicates severe mitral regurgitation because of poor coaptation of the valve leaflets. Diastolic function. It progresses from grade 1 to grade 4 as the disease progresses. Tissue Doppler findings, all the waves become small. The important differential diagnosis is ischemic cardiomyopathy. In ischemic cardiomyopathy, there is regional hypokinesis or akinesis. Scar tissue is important for the diagnosis. It is diagnosed by tissue Doppler imaging and by other methods. Look at this picture. Parasternal long axis. Look at the septum. This is thinned, scarred, and akinetic. There is no systolic thickening. The posterior wall has undergone compensatory hypertrophy, and there is a chink of effusion in the pericardium because of failure. This is ischemic cardiomyopathy. Same patient, apical four-chambered view. Look at the septum. The septum is thinned, scarred, and akinetic, and the lateral dimensions of the left ventricle are increased. The differential diagnosis includes a wide variety of cardiac diseases like ischemic cardiomyopathy, valvular heart disease, hypertension, viral myocarditis, diabetes mellitus, systemic disorders, neuromuscular disorders, toxic, and peripartum cardiomyopathy. These are the features of poor prognosis: low left ventricular ejection fraction, large LV dimensions, LV mass, increased LA volume, the higher degrees of diastolic dysfunction, dyssynchrony, and myocardial ischemia. This is a variety of dilated cardiomyopathy, which is known as non-compaction of left ventricle. In the fetal life, the ventricle develops as small masses of muscular tissue which coalesce to form the compact myocardium. But in non-compaction, you see that there are small bits of myocardial tissue in which the blood flows in during systole and flows out during diastole. The same thing used with a contrast, you can see the gaps in between the non-compacted myocardium here also. This is arrhythmogenic right ventricular dysplasia. The right ventricular free wall is replaced by fibrofatty tissue, and here you can see an aneurysm formation. The RV is dilated, and in the next picture, I will show you a low pressure TR here. These people are notorious to have ventricular arrhythmias, and these are the cause of death in many cases, and an implantable device is necessary to prevent death from ventricular arrhythmias. Why is echocardiography important in the management of dilated cardiomyopathy? Dilated cardiomyopathy has a variable course. The patient can improve, stay improved for a variable length of time. Later on, there can be flare-ups of the disease. And so the role of the echocardiographer is important to follow up the natural history of the disease. Then to identify the patients who have a poor prognosis, assess the patient for cardiac resynchronization therapy, and assess the patient for AICD. This is how an AICD is put. This is the machine, and this is one lead which goes into the coronary sinus, into the left ventricle. This is the right ventricular lead, and this is the diagram. Next, we come to the topic of hypertrophic cardiomyopathy. Again, this is a normal heart, postmortem specimen. This is a heart of a person who had hypertrophic cardiomyopathy. Look at the interventricular septum. The septum is very much thickened compared to that of the normal heart. There are different varieties of hypertrophic cardiomyopathy: reverse curvature, neutral, sigmoid septum, apical, and others. And the first two are strong predictors of genopositivity. I'll discuss that later. This is the systolic anterior motion of the mitral valve. As the systole progresses, a part of the mitral valve curves and hits the interventricular septum, and this is known as systole. See this part. This is systolic anterior motion. The anterior leaflet is touching the interventricular septum, and this is causing obstruction to the outflow of blood from the left ventricle. Same patient, see the systolic anterior motion of the mitral valve. Here, the leaflets apparently cross, they don't really cross, and this anterior mitral leaflet hits the interventricular septum. Apical three-chamber view, same systolic anterior motion over here. Look at the septum here. It is much thickened compared to the left ventricular posterior wall, and the ejection fraction is supernormal. M-mode characteristics, there is something known as systolic anterior motion. This is systole, and the mitral valve goes forward. Here in systole, it is flat, but if it went forward, then it is systolic anterior motion. See, this is the normal mitral valve. It closes like a parallelogram, and here, because of mid-systolic obstruction, there is a notching in the leaflets of the aortic valve. LV diastolic dysfunction, grade 1 diastolic dysfunction, the E is small and the A is large. If you put a color Doppler across a line across the left ventricular outflow tract, you will see a dagger-shaped profile. See, this is a dagger-shaped profile. When you interrogate a patient of hypertrophic cardiomyopathy, you have to find the site of obstruction, put the line across the left ventricular outflow tract, turn on the PW Doppler and move the sample volume from apex to base and see where the maximum velocity is. That is the site of left ventricular outflow tract obstruction. LVOT obstruction, this is before Valsalva, it was about 42. After Valsalva maneuver, it became 60. So this is provocable obstruction. A significant gradient is one that is more than 30 millimeters mercury. If gradient is absent in the resting, but provoked by the Valsalva maneuver or amyl nitrite, it is called latent obstruction. Do not use inotropes because you will get false positive results. Remember that the obstruction may not lie in the left ventricular outflow tract. It may be the mid cavity. So as I told you, you will have to scan the LV from the apex to the base with a pulse wave Doppler sample volume to detect mid cavity obstruction. This is mitral regurgitation caused by hypertrophic cardiomyopathy. If there is SAM, there is LV outflow tract obstruction, and there is also mitral regurgitation. When one exists, the other has to be present. This is apical HCM. The apical region of the left ventricle is disproportionately thickened. The other portions of the LV may not be thickened. The hallmark of the apical HCM is obliteration of the LV during systole so that the remaining portion of the LV shows an ace of spades appearance. If you look at this picture, you will see that the apex becomes obliterated during systole. If you are not sure with this picture, see the short axis view. The apex becomes obliterated during systole. What is the importance of echocardiography in the management of hypertrophic cardiomyopathy? Assessment of the effectiveness of medical therapy in reducing the LVOT gradient. Assessment of the patient before and after alcohol septal ablation and the role of the myocardial contrast echo. Before you try to do alcohol septal ablation, look at the septal perforators of the left anterior descending artery and find out the vessel which is most suitable for the septal ablation. If you obstruct a very big vessel, there's a chance of perforation of the interventricular septum. Next, assessment before, during, and after surgical myectomy. If the interventricular septal thickness is greater than 30 millimeters, it predisposes the patient to malignant ventricular arrhythmias. Herein lies the role of AICD. Echocardiography is also important for the detection of latent disease in the first degree relatives of the proband patient. Now, these are the echo markers of poor prognosis. Massive left ventricular hypertrophy. What do we mean by massive? The wall thickness is greater than or equal to 30 millimeters, especially in young patients. LV apical aneurysm combined with localized myocardial scarring and a monomorphic VT. End-stage disease that is associated with poor systolic function. Large transmural infarction caused by alcohol septal ablation. Remember that although the LVOT gradient predicts heart failure and death, it is a poor marker for prognosis. Differential diagnosis: hypertensive heart disease, valvular heart disease, infants born of diabetic mothers, tumors invading the interventricular septum, and patients undergoing hemodialysis. This is one of my patients. See, this patient has got a highly calcified aortic valve. Someone mistakenly thought that this was hypertrophic cardiomyopathy because of the left ventricular hypertrophy and T-wave inversions seen on the routine ECG. And look at the gradient that we have got. The maximum gradient is 157 millimeters mercury and peak gradient is 80 millimeters mercury. This patient underwent a successful aortic valve replacement. This is another thing which is often confused with hypertrophic cardiomyopathy. This is a sigmoid septum. When taking the measurement, do not measure here. Try to take the measurements over here because this will give you a false diagnosis of hypertrophic cardiomyopathy. Very frequently, young athletes come for cardiac evaluation, and one has to tell the parents whether this is athlete's heart or hypertrophic cardiomyopathy. These are the characteristics of athlete's heart. LV wall thickness less than 14 millimeters. Genetic testing will solve the problem. Family study, look for hypertrophic cardiomyopathy in other relatives. PW Doppler of the mitral valve should be normal in athletes. The E prime should be more than 7 centimeters. Dilated LV cavity. And finally, regression of the left ventricular hypertrophy following 4 to 6 weeks of deconditioning. Days have changed, and now we depend on genetic diagnosis of hypertrophic cardiomyopathy. This is a picture showing the different places where genetic defects can take place. They can be wrong in the myosin heavy chain, in the myosin regulatory and essential light chains, and in the troponins C, I, and T. And these can be detected by a pan-cardiomyopathy panel of blood tests. The treatment of hypertrophic cardiomyopathy can be medical with beta blockers or non-dihydropyridine calcium channel blockers. Sometimes you can use disopyramide. Then there can be surgical when you chop off a portion of the outflow tract, and interventional when there is injection of absolute alcohol in the first septal branch of the left anterior descending artery. This is how alcohol septal ablation is done, and the picture on the right shows that the septum has become smaller and it has become thinner. If you look at the gradients have also decreased.
Abhijit, can we hold on at this point and take up some questions?
Yes, sir. Are there any questions
for this session? It's only 4 minutes are left, so we can take a few questions from the delegates.
Right, sir. Any questions, please?
Can we differentiate ischemic versus dilated cardiomyopathy if there are no original wall motion abnormalities at rest?
Ischemic cardiomyopathy and dilated cardiomyopathy.
This is wall motion abnormalities at rest.
There are different ways of distinguishing, but since ischemic cardiomyopathy is a potentially treatable form of disease, I think the best thing to do is to do a coronary angiogram. Otherwise, you'll get into legal problems.
So any case of
one thing over here.
See, there are other alternatives. For example, you can do a dobutamine stress echo. You can do nuclear cardiology testing. These are important. But then in this world where doctors are frequently snared into medical legal cases, when you are in serious doubt, it is better to do a coronary angiogram.
I absolutely agree, Dr. Abhijit. All DCM should undergo an angiogram to rule out between dilated versus ischemic. By echocardiography, there is one way where you can get a hint or a doubt whether this is DCM versus ischemic cardiomyopathy. Answer is you do a tissue Doppler imaging. I have told you already all this. If you do a septal annuli S wave evolution, in DCM, you'll find almost all of them will be truncated, including RV free wall. Whereas if you have a variable tissue Doppler imaging, in those cases, your suspicion goes toward ischemic cardiomyopathy. Like suppose your septal is 4, so all of the annuli shows 4. It means possibly dilated cardiomyopathy. If septal shows 4, other 6 shows 7 or 6, it means you should have a thinking for ischemic cardiomyopathy. Second important thing, which you must have observed in your practice, if you treat dilated cardiomyopathy with ACE inhibitor with diuretics, the dilated versus ischemic will start separating automatically with decompression therapies. Dilated will remain as such. Ischemic will start showing wall motion abnormalities within a 2 weeks time maximum. But as Dr. Abhijit said correctly, all of these people should undergo evaluation by coronary angiogram to look for the dilated versus ischemic, and if it is ischemic, always look for a viability study by dobutamine echo or other modalities, nuclear or thallium, and if they are viable, subject them for intervention. Or during angiogram also, you can look for FFR. If FFR shows viability, you should open up that vessel. Am I correct, Abhijit?
Sir, there's something which I want to add at this stage. Dr.
Sure,
Sanjay
please.
Bhatt, thank you for your question. You know, there is something known as strain imaging. Have you ever heard of that?
Yes, yes.
Strain basically means contractility. And with the help of strain imaging, if you do a bullseye plot, then in many cases you can see that in ischemic cardiomyopathy, there are areas in the affected territory which show decreased strain. So technology is improving fast and the echocardiographies are not lagging behind.
Thank you, sir.
To close down at any moment, so we'll log on to session 2 immediately 5 minutes after that.
Right, sir. Thank you.